back to the pupil. So we did touch upon this very briefly, but let's go more into mechanisms about how the pupil changes. And it's kind of cool, like if you look in the mirror and just look at your pupil, chances are you'll probably see your pupil twitching, especially if you're in a room with varying lighting. Now there's the pupil and the iris. So within the iris you have these two muscles, and one of them is called the dilator pupillae. And dilator sounds like dilate, right? So getting bigger in diameter. So dilator pupillae. So what's going to happen is that this opens up the iris and opens up, widens the pupil in response to decreased light intensity. And why? Because if you have less light, you want, or less light, ambient light in the room or wherever you are, you want to open up your pupil so you let more light into your eye and retina. So again, think of it this way. Even if you're not scared of the dark, think of a scary dark place as causing all the sympathetic activity. So increased sympathetic stimulation is going to dilate your pupils and bring more light in. So this is why sympathetic activity causes dilation by activating, so you have sympathetic nerve fibers innervating this dilator pupillae. Now, this is the outer part right here that looks like a barrel, but this inner ring right here is what you call the sphincter pupillae, and this part activates in response to increased light intensity. Or say you're in back in a movie theater and you go out, even if you're going out to the lobby, you're like, whoa, and you're like, oh, it's too bright, and you might be like shielding your eyes. Well, this is a natural reflex of your pupils and iris. So what's going to happen is, like, when you go from a dark to light place, you're going to have increased light. So you want to reduce the amount of light into your brain, and your pupil and iris got used to that low amount of light. Now it wants to block and kind of gradually accommodate to that increased amount of light. So you're going to shut the iris and the pupil. So this is increased parasympathetic stimulation and going to cause constriction. So again, even though you could consider like the iris as dual innervation, but it's not the same muscles. They're more like opposing muscles than fibers innervating the same tissue. Now, let's review that. So the sympathetic nervous system, sympathetic activity is going to activate the dilator pupillae, and that's why the fascicles are arranged like the spokes of a wheel. What happens is that as you dilate, these are going to constrict, and this is going to pull the pupil wider so you have more light coming into your eye and your retina. In the parasympathetic activity, this is going to constrict the sphincter pupillae, so it's going to constrict just like a purse string or like a drawstring bag. So again, when you constrict the circular muscle, it's going to narrow and close off that muscle as well. So again, they're not the same muscles. One dilates and pulls outwards, the other constricts like that, a circle. Okay, let's talk about parasympathetic pharmacology. So there's a class of them called anticholinergics, and what they do is block the effects of acetylcholine. So that makes sense, like cholinergic sounds like choline. Anticholinergic block the effects of acetylcholine. And if you remember with the synapse, with the preganglionic and postganglionic synapse, you have acetylcholine at that part of the parasympathetic nervous system. But you also have acetylcholine being secreted by postganglionic cells as well. So anticholinergics are able to block the parasympathetic block parasympathetic activity at two different synapses, two different types of synapses. So it blocks the parasympathetic nervous system. Go back to that pan-amide. The A stands for acetylcholine, right? Now you also have anti-muscarinics, but instead of blocking acetylcholine in general, what this does is target those target tissues that are innervated by postganglionic neurons. So there's a class of drugs called muscarinic receptor antagonists, and an example of this is atropine. Now, atropine comes from this plant, is actually a natural product. So I know, like, there are some alternative medicines that say like you can use plants for everything, but there's also like some extremists who's like, yeah, there's no such thing as like that. Well, plants actually do have a lot of chemical properties that can cause pharmacological effects, and this is an example of one of those natural products that can become, they just make it very pure and then they use it in this purified form. So this is nightshade, or the Atropa belladonna. So poisonous by itself, but if you take pharmacology, you'll probably learned this phrase from the Paracelsus, the father of toxicology, that the dose makes the poison. So if you eat nightshade, yeah, you should call the poison control center immediately. But if you have atropine given in a this one chemical from the nightshade, but given in controlled doses, it can be used for therapeutic uses. So what can you use it for? Well, maybe I want to use it, say we have too much cholinergic activity, too much acetylcholine, or say we want to increase heart rate, because again, parasympathetic is going to decrease heart rate, but say we want to increase heart rate. So we might add atropine in certain situations, or say we're doing gastrointestinal surgery, so something on the stomach, and we want to reduce the amount of gastrointestinal motility, or say we have too much saliva. Remember, saliva is also secreted in response to parasympathetic activity. So maybe if we give atropine, we might add, or some sort of anti-muscarinic, this can help to dry up the mouth. But the thing is that the side effects, well, you might get a dry mouth if you use atropine, but you're not operating on salivary glands. And pupil dilation. And you're like, wait, how does that work? So if you have something that's anti-muscarinic, it's going to block parasympathetic activity. Remember that with the pupils, that with parasympathetic, that's going to constrict. But if you're blocking the parasympathetic, it's going to do the opposite. So you're going to have a lack of constriction, and this is why when you have an anti-muscarinic, it causes pupil dilation, because again, it's anti-muscarinic. And I talked to my optometrist, and he said, yeah, atropine is like super cut. If you've gone to like optometrist and got your pupils dilated, they put that chemical in there, and then it's like you have to put shades on when you go outside because there's way too much light. And he's like, yeah, we don't use atropine. That's going to keep you dilated for like hours. So what they use is this tropicamide, but this is like a less long acting. It still is an anti-muscarinic. So yeah, atropine is very great, but super powerful. You don't want to use that for routine eye exams. And drowsiness as well. And why is that? Well, the drowsiness is commonly found in a common side effect of anticholinergic. But where else do you find acetylcholine? Well, yeah, you find it on the parasympathetic nervous system, but go all the way back to Unit 2 and the neuromuscular junction. What's that neurotransmitter at the neuromuscular junction? Acetylcholine, right? So if you're blocking acetylcholine, this can also affect neurotransmission of acetylcholine up here, but also in your muscles as well. So this is why typically when you have anticholinergic, there's a common side effect is lack of coordination. You're affecting the brain, you're affecting neurotransmission to skeletal muscles. So if you get an anticholinergic, or if you prescribe one, this is why on the bottle it says do not drive, because you need your brain, you need your skeletal muscles, you need your control to do something like driving, right? Or don't operate heavy machinery, because again, if you're inhibiting all of that, that causes a potentially dangerous situation.